I'm going to talk about the mechanism of action of Reducer, and this is a work in progress, and many people in the room, Ranil, for example, Francesca, I can see you in the room as well, have contributed to this journey. It is an ongoing journey, but it does tell us a little bit how we can optimize the therapy. And I think it does talk to us this, as physicians, we like to be able to get our hands around the problem and say, okay, I understand how this works. Therefore, I believe in it. There's an element to this, and you probably didn't think I was going to start with the formula, but this is a very common drug which we use all the time. It's one of the commonest prescribed drugs in the world, and we really have got absolutely no idea how it works, but we know it works. This is actually metformin, which is used to treat diabetes, of course, and has been shown to reduce malignancies and cardiovascular disease and all sorts of incredible things, but we've really no idea how it works. And that's often because the biology that we deal with is so complex and adaptive that it's quite difficult to be too reductive about things. We can remember we're doing an input, but the output is very challenging to predict on occasions. And angina, as Ranil has so beautifully shown from the last slide, is a pathway. It starts with a signal from the heart, and it ends up with an output from the brain, and we're only really intervening at one part of that signal, and it's no wonder that we find it very difficult to modulate angina, and so many of our treatments are limited. And that desire for understanding with physiology, you can see for FFR as a classic example of that, where we try to demonstrate angina as a single reductive model. Epicardial stenosis, increased resistance to flow, compensation from the microcirculation, this vasodilatation, up to a point where it can't compensate anymore, and then you get either decrease in flow or at least decreased coronary flow reserve. But of course, things are a lot more complex than that. It's just that helps us on the pathway to understanding. So to get to the answer of why the reducer might work, we have to zoom out a bit and think about how a heart works in a normal environment and ask ourselves the question, well, how is flow maintained in a normal heart, and are there components within the normal heart? So the first thing I'd like you to consider is the difference between the epicardium, where most of the coronary arteries run, and the subendocardium, which is the inner surface of the myocardium. And the major difference, of course, is that the endocardium is exposed to pressures within the cavity of the heart. And there is actually a difference, of course, between normal epicardial flow in systole and diastole. But the key concept here is that there's a differential difference between the epicardium and the endocardium. And that differential difference is dominated or driven by the pressure within the ventricle. So if you look at normal flow between epicardium and endocardium, you'll see that this differential difference in terms of vasoconstriction is not that marked, but you see it's slightly exaggerated in the subendocardium, but not to a significant degree to lead to any pathology. Obviously, epicardial flow is diastolic, you all know that. So the constriction occurs primarily in systole, and it's exaggerated in the endocardium. But everything happens in terms of the signaling at a capillary level. That's where the oxygen exchange is and so on. And of course, like everything in physics, fluid goes down perfusion gradients from high pressure to low pressure. And the less the perfusion gradients, in general, the less the flow. But in a diseased heart, things change a lot. Obviously, we kind of know that obstructive coronary disease, and we're talking about this primarily today, is the primary reason we see patients in our clinic with angina. And this increased friction to flow cause ultimately, once you auto-regulate it, a reduction in perfusion pressure. And critically, this is where you see the impact of the subendocardium come into play because of that reduction in flow. So once again, if we look at this difference, this auto-regulation can compensate, but it's the point where it fails to compensate that patients get angina, where they fail either due to a problem with the microcirculation or due to a severity of stenosis that they can't further compensate for this reduction in perfusion pressure. And of course, often this is due to factors like hypertension or left ventricular dysfunction, where you get this rise in pressure within the ventricle, and this compression that we see in systole is actually exaggerated in the endocardium. So you can see epicardium at the top, endocardium at the bottom. And remember, everything is flow mediated. So higher resistance means less flow. So if you're a blood cell and you're trying to choose where you should go, and remember the demand is the same in both parts of the things, you're going to go where there's less resistance. And that means critically that flow will go preferentially to the epicardium over the endocardium. So if you're going to see ischemia, you're going to see it first in the endocardium because of this pressure differential. And that means reduced perfusion back down to the capillary level, and ultimately that means a higher signal given, and therefore, of course, we translate the signal as angina. And we can see this across imaging studies. So that's the pathophysiology, which is well established and well evidence-based. The question that we're here to answer today is, well, how does the reducer work, or how might the reducer work? Does it redistribute flow? Now, the first question I asked myself when I saw this question about flow was, can you increase flow? And the answer to that, it seems quite intuitive, that you shouldn't be able to increase flow, because remember, you've got a microcirculation that's maximally vasodilated, whatever those limitations are. And in these refractory patients, we're saying we're not improving epicardial stenosis. So we can't change absolute flow, but can we redistribute flow to the areas that need it most? And we established already, I hope, that that area is the subendocardium. So what the reducer does primarily, or what it should do if it's implanted well, is increase resistance to venous drainage. So in other words, there should be a pressure gradient across the reducer where it creates this back pressure effect. And the best way, I think, to conceptualize this is PEEP, or positive airway pressure, where you create a gradient that actually reinflates alveoli, and that then augments inspiration. So even though you're creating increased resistance, it results in a funny way to decreased resistance, because you reinflate the capillaries in the right area, if you like. And therefore, of course, you're not increasing flow, you're just redistributing flow, because you're changing the pressure differential that was previously there, or at least in a positive way, between the epicardium and the endocardium. Now, that's all very well. We can chat about whether it works or it doesn't work, but we've really got to evidence some of these things. We've got to have some evidence that supports that hypothesis. And ORBITA-COSMIC, which of course was a sham control study, did look to answer some of these mechanistic questions. And the first question they asked was, well, does it increase total myocardial flow? And I always thought that didn't make any sense to me. And that was the case. There was no difference in total flow, and really, how could there be? But was there a difference in regional flow if you stratify it according to ischemic or non-ischemic? Well, actually, you could see that there was this redistribution to ischemic areas at stress between the endocardium and the epicardium. So in some ways, what we were doing was redistributing flow to the areas at most need by this back pressure effect. And that was highly significant in terms of the probability of benefit from the Bayesian analysis. And if we go back to what you're essentially doing is creating a stenotic gradient, so the venous drainage is part of that is the implant itself, because it's an R-shaped stent, but part of it is the endothelialization. And you might therefore hypothesize that the benefit might not be, maximal immediately, but it might improve over a period of time. And in fact, you did see that at 3 months. So we're left with this, what seems to be a cogent hypothesis, that if we increase the pressure gradient, we end up redistributing flow from epicardial to endocardial. So rather than augmenting flow, it's flow redistribution.